Welcome to the deep dive. Today, we're plunging into something that, well, it demands absolute speed and clarity in the ER. Subarachnoid hemorrhage, or SAH. It's a potential catastrophe, honestly. So our mission today, give you that clinical roadmap for spotting it and managing it fast.
Right. And SAH, what is it exactly? We're talking about a bleed inside the head, specifically in the subarachnoid space.
Right.
That's that little gap between the inner layers protecting the brain, the pia and arachnoid layers, and the real immediate danger. Blood pools there fast, and that spikes the pressure inside the skull, the ICP.
Intracranial pressure.
Got it. Exactly. And when that pressure gets too high, it starts crushing vital brain parts.
Yeah.
That's the life threat.
Which is exactly why we're doing this deep dive.
Yeah.
It's for anyone needing the quick version, the essentials on this. We're going to unpack the whole pathway, starting with just keeping the patient alive, stabilization, and then figuring out why it happened.
Yeah.
Trauma, or something else, like an aneurysm. Okay, let's get into it. First things first, the immediate crisis.
Oh.
So a patient comes in, you're worried about SAH. First move is always the ABCDE assessment, right? Just checking stability.
Yeah, absolutely. Airway, breathing, circulation first. If they're unstable, you don't wait. You might need to intubate, get them on a ventilator, protect that airway, make sure they're getting oxygen. That's priority one.
Okay, but while you're doing all that, you've got to be watching for signs that the pressure inside the head, the ICP, is getting dangerously high.
Right. And that's a key question, isn't it? How do you know if that pressure is critical, maybe even about to cause herniation without, drilling a hole right away?
Yeah, what are the telltale signs? It's fascinating how the body sometimes signals this huge danger.
It really is. There's a classic pattern we look for. It's called the Cushing triad.
Cushing triad, okay.
Yeah, it's not just random symptoms. It's the brainstem basically screaming that it's not getting enough blood because it's being squeezed. So you see three things. Bradycardia, a really slow heart rate, hypertension, super high blood pressure, and irregular breathing. Weird patterns.
So the brain's trying to force blood flow in by jacking up the body's pressure.
Exactly. It cranks up systemic pressure. That's the hypertension trying to overcome the pressure inside the skull. And the heart rate often drops in response. See that trio, you know you're in deep trouble.
Okay.
Another really bad sign on exam. Pupils that are dilated, wide open, and don't react to light. That points strongly towards brain herniation possibly starting.
Right. So, okay, we see these signs. We suspect really high ICP. What do we actually do? What are the interventions? We're essentially trying to buy the brain some time.
Yeah, you need to act fast and hit it from multiple angles. Simple stuff first, like raising the head of the bed that helps blood drain out via the veins.
Makes sense.
Then sedation. Calm the brain down, reduce its energy needs, its blood flow demands, and, critically, hyperosmolar therapy.
Okay. Hyperosmolar, what does that involve?
Think of it like this. You give meds, like mannitol or super concentrated saline, hypertonic saline. It makes the patient's blood really, really salty, osmotically speaking.
Oh, okay.
So the blood acts like a sponge, pulling excess water out of the swollen brain tissue across the blood-brain barrier.
Right, using osmosis to pull fluid out. Clever. Basic physics, really.
Exactly. Now, if the pressure is high because the cerebrospinal fluid, the CSF, is blocked up and building inside the brain's ventricles, that's called ventriculomegaly, then you need to drain that CSF directly. Often that means placing an external ventricular drain, an EVD.
An EVD? And that does what?
It's actually pretty neat. It's got two jobs. One, it's a direct pressure monitor, gives you a continuous real-time ICP number.
Okay, direct measurement.
And two, it's an escape valve. You can open it up and drain off excess CSF to lower the pressure quickly.
Wow, so it measures and relieves the pressure. That's
Right.
quite a tool.
Yeah.
But what if even that doesn't work? The pressure stays sky high despite everything.
And you're really backed into a corner. The last resort, the extreme measure, is an emergency decompressive craniectomy.
Surgery.
Yeah. You surgically remove a piece of the skull bone. Sounds drastic, I know.
It does.
But it gives the swollen brain room to expand outwards instead of inwards and downwards onto the brainstem, which would be fatal. It just shows how incredibly high the stakes are in these first few hours.
Absolutely. Okay, so let's say we've navigated that initial ICP crisis.
Yeah.
The patient's more stable. Now we need to figure out why this happened. Time for some detective work. History, physical exam. Trying to sort out, was this caused by trauma or was it spontaneous, non-traumatic? Let's take the first path. traumatic SAH. That's usually more straightforward.
Generally, yes. Traumatic SAH, like the name says, it's tied to a physical injury. The story you'll typically get is recent head trauma. And the headache might actually be kind of non-specific. It might not be that sudden, explosive onset we'll talk about later. It could develop over a bit of time.
And on the physical exam for traumatic SAH, what are we looking for besides maybe confusion or altered mental status?
Well, the classic sign of blood irritating the meninges, those brain coverings, is nuchal rigidity. Stiff neck.
Okay.
Diagnostically, the go-to is an immediate, non-contrast head CT scan. For traumatic SAH, you often see the blood spread out over the surface of the brain in the cortical convexities.
On the curves of the brain surface.
Exactly. And you might see other types of bleeding too, like epidural or subdural hematomas, maybe some bruising in the brain tissue itself.
So the CT confirms it. What's the management plan then for traumatic SAH?
Now the focus shifts to preventing things from getting worse, secondary injury. Rebleeding is a big risk, or other bleeds getting bigger. So high blood pressure control is key. You don't want hypertension.
Right.
And crucially, if the patient has any bleeding disorder or they're on blood thinners, you have to reverse that coagulopathy immediately.
Makes sense. Yeah. Stop any potential for more bleeding.
Definitely. And of course, you get neurosurgery involved right away for potential ongoing ICP monitoring, maybe managing those other bleeds.
Okay, that's the traumatic path. Now, let's shift gears to where things often get, well, a lot more dramatic and, frankly, more specialized. Non-traumatic subarachnoid hemorrhage. This is usually the ruptured aneurysm scenario, right?
Almost always. And here, the patient's story, their history, is incredibly powerful. It's often your biggest clue.
What's the classic story?
It's the thunderclap headache. You'll hear patients say, verbatim, worst headache of my life.
Wow.
And the key thing, what makes it almost diagnostic, is the onset. The pain hits maximum intensity instantly. Bang. Not like a migraine that ramps up. This is 0 to 10 in a second.
Instant peak intensity. Okay, you also mentioned something about a warning sign, a headache before the big one.
Yeah, that's a really important point. It's called the sentinel headache.
Sentinel. Like a guard.
Exactly. Days, sometimes even weeks before the major rupture, the patient might have had a sudden, unusually severe, persistent headache. It's often from a tiny leak from the aneurysm that seals itself off, or maybe just the aneurysm wall stretching rapidly.
A small leak first.
It's a huge warning sign that often gets missed. It means the aneurysm is unstable, it's about to blow. If you can catch that, you could potentially intervene before the catastrophic bleed happens. It really underscores the importance of listening closely to that history.
Absolutely. So besides denying any recent trauma, what else in the history points towards an aneurysm? Any risk factors?
Definitely. You look for the usual cardiovascular suspects. Uncontrolled high blood pressure, smoking history is a big one. And then you have to ask about certain inherited conditions, things that weaken blood vessel walls. Our sources point to autosomal dominant polycystic kidney disease, PKD.
Right, kidney cysts, but also brain aneurysms.
Yeah, there's a known link. Also, certain connective tissue disorders like Ehlers-Danlos syndrome type IV and fibromuscular dysplasia, these are all red flags.
Okay. Now, the physical exam for non-traumatic SAH. You mentioned neck stiffness, maybe altered mental status, same as traumatic. But there are some really specific signs here, aren't there?
Yeah.
Especially with cranial nerves.
Oh, absolutely. The classic one is looking for signs of cranial nerve, the third palsy. The third nerve controls several eye muscles and the pupil.
Okay, what does that look like?
You see a combination of kyphosis, that's a droopy eyelid. Mydriasis, the pupil on that side, is wide open, dilated. And the eye itself deviates down and out. It can't look up or inwards properly.
Down and out pupil, droopy lid, big pupil.
Got it. And the reason for that is location, location, location.
Precisely. It's fascinating anatomy. This specific set of signs is highly suggestive of an aneurysm on the posterior communicating artery, the PCOM.
Why the PCOM specifically?
Because the PCOM artery runs literally right alongside the third cranial nerve. So as the aneurysm balloons out even a little bit, it squishes that nerve. Instant dysfunction. Those signs pop right up. It's a huge clue pointing to where the likely aneurysm is. Amazing anatomical clue. And even before imaging, looking in the back of the eye can tell us something. The fundoscopic exam.
Yes, definitely. You might see papilledema, which is swelling of the optic nerve head where it enters the eye. That's a direct sign of increased pressure inside the skull, pushing on the nerve.
Okay.
And sometimes, even more dramatically, you can see a specific type of bleed right on the retina itself. It's often boat-shaped or crescent-shaped, called a subhyaloid hemorrhage. Seeing that is pretty direct evidence of a significant intracranial bleed.
Okay, so all these red flags are waving. Thunderclap headache, maybe that's CN the third, palsy, maybe papille edema. We strongly suspect non-traumatic SAH. First imaging test is still the non-contrast head CT, quick and easy.
Right, that's the initial go-to.
But here's where it gets tricky, right? The CT isn't perfect, especially as some time has passed.
That's the crucial challenge, especially in the ER. A non-contrast CT is really good early on, but its sensitivity for picking up SAH drops off significantly after about 6 hours from when the headache started.
6 hours? Wow.
The blood starts to get broken down, basically. Its density changes, making it look more like normal brain tissue on the CT, especially if it's a small amount of blood. It gets harder to see.
So you've got this classic thunderclap story, maybe some signs, but the CT comes back negative. What do? You can't just stop there if you're still suspicious.
Absolutely not. If your clinical suspicion remains high, that story is just too compelling, and the CT is negative or maybe equivocal, you must proceed to a lumbar puncture, an LP, or spinal tap.
Right, the LP. That's the definitive backup test. What are you looking for in the spinal fluid, the CSF, that proves there was a bleed and you didn't just cause it with a needle?
Good question. You'll see red blood cells, obviously, if there's blood, but the key finding is xanthochromia.
Xanthochromia, yellow fluid.
Exactly. Xanthos means yellow. It's the yellowish tint to the CSF. Why is that the proof? Because it takes time, several hours, for the red blood cells that bled into the CSF to break down and release hemoglobin, which then gets converted to bilirubin, which is yellow.
Ah, so the yellow color means the blood has been sitting there for hours, before the LP was done.
Precisely. It proves the bleed happened earlier, spontaneously into the subarachnoid space, and wasn't just caused by the needle nicking a blood vessel during the procedure, what we call a traumatic tap. That time lag is the key.
Got it. So, okay, diagnosis confirmed. Either the CT was clearly positive, or the LP showed xanthochromia. We know it's SAH. Next step, find the source, especially if we suspect an aneurysm. That means more advanced imaging.
Yes, urgently. You need to visualize the blood vessels in the brain. Usually that means a CT angiogram, CTA first, which uses contrast dye with the CT, or sometimes the gold standard digital subtraction angiography, DSA, which is more invasive but gives incredibly detailed pictures.
Okay, and what do those results tell us in terms of next steps?
Well, it connects the diagnosis to the treatment path. If the angiography is negative, no aneurysm, no vascular malformation seen, then it's classified as non-aneurysmal SAH.
And what causes that?
Could be various things, maybe a small arteriovenous malformation that thrombosed, dural venous sinus thrombosis, vasculitis, other rare causes. Management there is generally supportive, keep the blood pressure well controlled, fix any clotting issues.
Okay, but if the angiography is positive, it shows an aneurysm.
Then you've found your culprit. It's aneurysmal SAH.
Huh.
Most often, these are saccular aneurysms, little berry outpouchings, usually located somewhere in the circle of Willis at the base of the brain where major arteries connect.
And once you find it, you have to fix it fast.
Yeah, right.
Prevent it from bleeding again.
Absolutely. Rebleeding is a major risk early on. So the neurosurgery and neurointerventional radiology teams jump in. They decide the best way to secure that aneurysm.
What are the options?
Two main approaches. One is minimally invasive, endovascular coiling or stenting. They go up through an artery, usually in the leg, thread tiny catheters into the brain, and pack the aneurysm sac with platinum coils or place a stent across its neck to block blood flow into it.
Wow. Through the blood vessels.
Yeah. The other option is traditional open surgery, a craniotomy, where the surgeon physically goes in, finds the aneurysm, and puts a tiny metal clip across its base, its neck, to pinch it off from the parent artery.
Coiling versus clipping.
Okay.
So the aneurysm is secured. Huge step. But the danger isn't over, is it? You mentioned delayed complications.
Not by a long shot. Securing the aneurysm is critical, but now you enter a period, especially the first 2 weeks, that's fraught with a different kind of peril. The biggest worry now is cerebral vasospasm and the delayed cerebral ischemia it can cause.
Vasospasm. The blood vessels clamping down. Why does that happen?
It's kind of ironic, really. It's the body's reaction to the blood that spilled into the subarachnoid space. That blood and its breakdown products are incredibly irritating to the smooth muscle on the walls of the nearby arteries.
So the irritation makes the arteries spasm constrict.
Exactly. They clamp down, sometimes severely, and when they clamp down, they cut off blood flow to the parts of the brain they supply. That causes ischemia, lack of oxygen, essentially a stroke, happening days after the initial bleed was fixed.
Wow. So the body's reaction causes a delayed stroke. That's tricky.
It's a major cause of poor outcomes after SAH. The highest risk for this vasospasm and ischemia is really concentrated in those first 2 weeks after the rupture.
So how do you fight that? What's the management in the ICU during that time?
Vigilance is key. Intensive monitoring. We focus on maintaining euvolemia, keeping the patient's fluid status perfectly balanced, not too dry, not overloaded.
Okay.
And crucially, we give a specific medication, the calcium channel blocker, nimodipine.
Modipine. Why that specific drug? Calcium channel blocker. How does that help?
It seems to preferentially help relax the smooth muscle in the cerebral arteries, the ones prone to spasming. It doesn't totally prevent vasospasm, but it significantly reduces the risk of that spasm leading to debilitating ischemia to stroke. It helps keep those vessels a bit more open despite the irritation.
So it's like a preventative anti-spasm medication for the brain's arteries.
That's a good way to think about it. It's standard of care after aneurysmal SAH for about 21 days.
Okay, that makes sense. Let's wrap up with maybe one or two final clinical pearls. What about seizures?
Good point. Seizures can happen in any patient with SAH, whether it's traumatic or non-traumatic. They need to be treated promptly if they occur.
Is there a difference in prevention?
Yes. If the SAH was caused by trauma, the guidelines generally recommend starting seizure prophylaxis, giving anti-seizure medication preventatively for about a week.
Okay, prophylaxis for trauma.
But for non-traumatic aneurysmal SAH, routine prophylaxis isn't usually recommended unless they've actually had a seizure. However, if the patient just isn't waking up well, they have persistent poor mental status after the bleed or after surgery. You absolutely need to consider continuous EEG monitoring, electroencephalogram, because they could be having subtle non-convulsive seizures without the obvious shaking that are still damaging the brain, and you wouldn't know it otherwise.
Right. Silent seizures frying the circuits. EEG is key there. Okay, so recapping the big picture, we went through that immediate crisis, managing ICP, watching for Cushing's triad, then the two paths. Traumatic SAH, often less traumatic onset, diagnosed on CT, versus non-traumatic, usually the aneurysm, that explosive thunderclap headache, maybe the C-enthothromb-Z, needing that careful CT, then maybe LP approach with xanthochromia.
Exactly. And connecting it all, you see that SAH management is truly a race. It's against time, against rising pressure, and then against those delayed complications like vasospasm. The whole diagnostic journey, using the history, knowing that 6-hour CT limit, relying on the LP when needed, really highlights how specific findings have to drive immediate, potentially life-saving actions.
It's an incredible cascade of events and interventions. Okay, final thought for everyone listening. Think about this. The delayed vasospasm, the highest risk in the 2 weeks after the rupture, is largely driven by the body's own inflammatory response to the blood. How does that fundamental process of healing, of cleaning up the mess, sometimes backfires and create entirely new life-threatening problems? It really makes you appreciate that fixing the initial injury is often just the beginning of the battle. Something to mull over. Thanks for joining us on The Deep Dive.